Hello, I'm Dr. Anthony Wheeler, and I'm going to tell you everything that you need to know about pathology. You're probably wondering what this image is here to the right. This is a histologic sample of a patient's skin that has disseminated intravascular coagulation. We're going to talk about that and much more. It's all in the book. Make sure you have this. Medical School Pathology and Step 1 Review. It has everything in it that you need to know for Step 1 and for your medical coursework. Highly recommended. Let's talk about heparin-induced thrombocytopenia. Heparin-induced thrombocytopenia is the destruction of platelets that results from heparin therapy. You can see here in the image actually what it looks like at the clinical level. That's why it's so important. Look at this patient's, dare I say, left leg. Heparin-induced thrombocytopenia is an immune complication due to antibodies directed against complexes containing heparin and a platelet factor 4. Platelet fragments could activate remaining platelets and cause thrombosis, leading to ongoing necrosis. Never give heparin to a patient that has experienced heparin-induced thrombocytopenia. For your intents and purposes, that's a rule. Here we have a schematic drawing of what heparin looks like for all you scientists out there. And here we have histological examination of an aspirated thrombi. Note that disseminated intravascular coagulation is due to the activation of the coagulation cascade by some sort of pathology. Again, we see disseminated intravascular coagulation. These arrows here indicate intravascular fibrin deposition. DIC can lead to ischemia and infarction that are brought on by widespread microthrombi. Bleeding is caused by factors in platelet consumption. Mucosal bleeding is a common symptom of disseminated intravascular coagulation. The majority of the time, DIC is due to another disease process. For example, obstetric complications, in which the amniotic fluid tissue thromboplastin initiates coagulation, or endotoxins from some sort of some microbial organism. Speak, I can do that. These bacterial wall and macrophage-derived cytokines, such as tumor necrosis factor and interleukin-1, cause endothelial cells to produce tissue factors in sepsis, particularly with E. coli or Neisseria meningitidis. Coagulation gets activated by adenocarcinoma mucin, right? So even malignancies can promote DIC. Or in that condition where you see the hour rods, you remember that term? Acute promyelocytic leukemia? Those primary granules actually can promote disseminated intravascular coagulation. That's why it's important to treat acute promyelocytic leukemia with all trans-retinoic acid, right? So those abnormal promyelocytes can continue on through the progression into neutrophils. Therefore, no more granules that can cause DIC. Also, coagulation can be activated by rattlesnake venom. For all you hikers out there, be careful. Laboratory findings of DIC include decreased platelet count, decreased fibrinogen, increased PT and increased PTT and increased INR and increased, importantly, D-dimer levels. If you have a peripheral smear that the pathologist is going to review on the report, you might see mention of helmet cells and schistocytes. Also, elevated fibrin split products are present, typically D-dimer. The best screening test for disseminated intravascular coagulation is elevated D-dimer. Remember that, it comes up a lot. The D-dimer is from splitting of cross-linked fibrin. The D-dimer is not derived from splitting of fibrinogen. Treatment of disseminated intravascular coagulation includes obviously addressing the underlying cause, as well as transfusing cryoprecipitate, which contains coagulation factors, and blood products if clinically indicated. After the injured vessels heal, the thrombus is removed by normal fibrinolysis. Plasminogen is transformed into plasmin by TPA, tissue plasminogen activator. Plasmin breaks down coagulation components, degrades serum fibrinogen and fibrin, and prevents platelet aggregation. Plasmin is deactivated by alpha-2 antiplasmin. However, plasmin overactivity, which results in increased cleavage of serum fibrinogen, is the cause of fibrinolysis disorders. So let's talk more about disorders of fibrinolysis. Examples of plasmin overactivity include radical prostatectomy due to release of urokinase causes plasmin to be activated, or reduced synthesis of alpha-2 antiplasmin due to liver cirrhosis, or increases hemorrhage while presenting, such as it resembles disseminated intravascular coagulation. Laboratory findings in disorders of fibrinolysis include increased PT, increased PTT, increased bleeding time, increased fibrinogen split products without elevated D-dimer, and a normal platelet count. Plasmin destroys coagulation factors and blocks platelet aggregation. Treatment is aminocaproic acid, which prevents plasminogen activation. That was a quick one. That was a good one. Remember all of it? It's all testable material, especially acute promyelocytic leukemia. Make sure you know what our rods look like. If you don't know, I'm going to have a lecture where I highlight that later on. So make sure you're subscribed. Make sure you're using your book. It's all in there. If I was you, I would have had it a long time ago. Keep studying. Help your friends. Keep learning and growing. And I'll see you next time. Good luck.